Now we present Dr. Ahmad Naga for clinical and hemodynamic outcome of morbid obesity patients having severe CVI with and without bariatric surgery, a comparative study.
Thank you, and sorry for being late. I should thank Dr. Hisham Sharaf and Dr. Adwan for the very nice organization and meeting. I will share with you one of the studies we've just been doing in Alexandria, along with my professors and colleagues, Dr. El Sha'lan, Dr. Ali Imam, and Dr. Hassan Lutfi. It's about the clinical outcome of morbidly obese patients with severe CVI manifestations with and without bariatric surgery. So I think every day we face patients having CVI manifestations and they are quite obese. And usually it is a wise decision to ask them to go back and try to lose weight before you intervene in any way. And even we sometimes tell the patient that the varicose veins apparently will become more evident, but whatever you will do now will be less efficient than doing it if he lost weight. So these manifestations are greatly differ from being mild peritibial edema to venous claudication to even venous ulcers. And the reason why we refrain from intervention, because we know that surgical intervention, those patients having BMI more than 30 is associated with increased anesthetic risk, wound infection, and recurrence rate. So here comes the role for the bariatric surgery, which is nowadays indicated for patients having BMI more than 40 or more than 35 with two comorbidities. So the aim of our study was to compare the severity of CVI manifestations in terms of clinical picture in morbidly obese patients who underwent bariatric surgery with those who haven't. So we did a study involving 123 patients. All of them had morbid obesity with CVI manifestations, and we divided them into two groups. Group A, those who had the bariatric surgery, and they were 59%, and the rest didn't have any sort of weight loss. Both groups were offered conservative measures in the form of elastic stockings, elevations, and medications. Only Group A were offered bariatric surgery in the form of sleeve or gastric bypass. The other group were not offered any sort of weight loss, even diet. All patients having DVT or varicose vein surgery in the past were excluded. The clinical assessment was carried by disease-specific tools like the Chronic Venous Insufficiency Questionnaire, Charing Cross Venous Ulceration Questionnaire, Villalta scoring system for those having PTS, and physician-generated tools as well, like the SEEP classification, the venous severity scoring system, and quality of life assessment as well. So these were our results. BMI in those who had surgery obviously dropped from 51 to 32, and this was statistically and clinically significant. Group B didn't have any significant weight loss. As regards the Charing Cross Venous Ulceration Questionnaire, it dropped from 82 to 38 in those who lost weight by the surgery, and this was again statistically significant, and the other group didn't show any significant result. For those having PTS, the Villalta score dropped from 20, which is classified as severe, to 8, which is classified as mild, according to the score, with non-significant change in the other group. The median venous disability score, one of the parameters of the venous scoring system, dropped from 2 to 0, again with non-significant change in the other group. The venous clinical severity score dropped from 8.6 to 2.1, again with non-significant change. Of course, apart from all these parameters, clinically, the patient felt marvelous improvement in his CVI manifestations, and that's how we formulated the results according to these scores. The quality of life improved from 43 to 87 according to the SF36 score, with non-significant change in the other group. So in conclusion, weight loss by bariatric surgery is an efficient mean of improvement of severe CVI manifestations as compared to not losing weight at all. It significantly increases the ulcer-free period, decreases venous claudication, and improves the quality of life. We believe that this study can aid bariatric surgeons in counseling their patients who suffer also from CVI manifestations preoperatively by providing them with evidence-based data about the effect their surgery will have on their symptoms. Further research is required in this field to precisely determine which group of patients with CVI manifestations can benefit most from bariatric surgery. The relation between morbid obesity and pelvic venous obstruction is an untouched area of research, as long as I know, that might lead vascular scientists to amend the guidelines as regard iliac vein endovascular interventions in the future. To be honest, we tried to collect data to compare the duplex findings pre and post-operative in terms of blood flow volume in the common femoral veins, phasicity, velocities, things like that. And we are still working on this, and we are trying to correlate findings together. I finished, thank you. We are all waiting for you in the next huge VSE summit, Egyptian Vascular Summit 2020 in Alexandria, Georgia. Thank you.
Thank you, Dr. Ahmed, for your very nice presentations.